series that we're putting on for our response across BLMK for the current Group A Strep outbreak. We've put this together as a Children and Young People team, and we have several team members presenting today from secondary care and also from our emergency response team. And I'm just going to meet people as they come in. And also our medicines management team. My name is Shankari, Dr. Maha. I'm a GP based in Milton Keynes and I work in Luton. And I'm here today as the strategic lead for Children and Young People across BLMK. Sunita, would you like to introduce yourself?
Hello, everybody. Good evening, and thank you for giving up your time today. I'm Sunita Chakrabarti. I'm Deputy Senior Responsible Officer for Children and Young People in Maternity across Bedfordshire, Luton, Milton Keynes, and a clinical lead here in BLMK ICB, Integrated Care Board. Welcome to everybody. I will be facilitating some of the questions and feeding it back to our speakers. So please post your questions onto the chat function and hope to talk to you soon.
So I think we can kickstart things. I can see people still coming in, but I'm just conscious of time.
Don't worry.
So
yeah. I can admit people, Shankari. So if you want to start, if Ronnie introduces himself, and I'll keep it admitting people, and I'll go off camera and just watch the chat box.
So as Sunita said, just keep your questions coming, and we'll try and answer them as and when the right speaker comes along to address those, if that's okay. And whatever we can't answer today, we will still be answering, and we'll be posting all the frequently asked questions on our website, and we'll share a link for that on this chat. So thank you, and also please do keep an eye on the chat because our comms team is going to be putting on some other really useful information that's come out in the last 24 hours from the Royal College of Paediatrics and RCGP, and also we would recommend that you guys have a look at the GP bulletin this evening because again we've put some really useful links on there as well. At this point I want to hand over to Dr. Misquith. He is a consultant paediatrician at L&D and the clinical director there for paediatrics. Ronnie, I'll let you take over.
Okay, thank you, Shankari. Good evening, everyone. Thank you for giving me this opportunity. If Abu Bakr, can you share the screen and then we'll go through. Right. Are you able to put on the presentation mode or? Okay, yeah, that's great. So as you can see on the picture, that is how the Streptococcus looks like on the microscope, and the enlarged version next. Next, please. So I'll try to cover a little bit of the background about the current situation and also about the infection, then the signs and symptoms, the treatment, when to escalate and when to notify. Next, please. So the background, Group A Streptococcus is a bacteria that can colonize the throat, skin, and the anogenital tract. It spreads by respiratory secretions, by droplet infections, and also from the surfaces that are contaminated with those secretions. It can cause a diverse range of clinical presentation like tonsillitis, pharyngitis, impetigo, and erysipelas that you can see on the picture. It can also cause cellulitis and lower respiratory tract infection and the scarlet fever, which we'll look in a little bit more detail. It can also cause invasive Group A streptococcal disease, that is pneumonia and empyema, septicemia, which sometimes can result in meningitis, streptococcal toxic shock syndrome, and septic arthritis as well. Next page. So we are in the current situation because since September, 15 children under 15 years of age have died in UK due to Group A streptococcus infection. 13 in England, 1 in Northern Ireland, and 1 in Wales. So there is increased circulation of group A streptococcus in the community due to the social mixing following a period of social isolation during the pandemic. One of the estimates is that we are seeing about 4 to 5 times more of group A streptococcus circulating in the community. There is also high levels of respiratory viruses that are circulating currently, such as RSV, flu A, flu B, rhinoviruses, enteroviruses. Next, please. So the scarlet fever is usually a mild illness, but it is highly infectious. So the first symptoms are fever, sore throat, headache, nausea, and vomiting, which are common to many viral infections that we see as well. Usually after about 12 to 48 hours, a characteristic fine rash develops, typically on the chest and abdomen, and then rapidly spreads to other parts of the body. As you can see in the picture, that is what a typical rash looks like. On a darkly pigmented skin, the rash may be harder to see, but when we feel the skin, it feels like sandpaper. Next, please. The other features include a fever, which is usually 38 degrees or 101 Fahrenheit or higher. There can be white coating of the tongue, which peels a few days later, looking red and swollen, what we call a strawberry tongue. There are swollen lymph nodes in the neck. There can be flushed red face, usually the cheek, but there is some sparing around the mouth, what we call a perioral pallor. They will generally feel quite tired and look unwell. And there can be peeling of the skin of the fingertips, toes, and groin as the rash fades in a few days. Next, please. So how to differentiate the sore throat, whether it is a viral or a bacterial infection. Commonly, it is a self-limiting condition, and majority of it is caused by the viruses. To differentiate whether to give antibiotics or not, there are certain clinical prediction rules, and the common one that is used is the fever pain score, which includes a fever in the last 24 hours. That means with a viral infection, you may have a fever for 1 or 2 days, and if it has settled and in the previous 24 hours there hasn't been any fever, it is probably a viral illness. It is getting better. Onset of the symptoms usually less than 3 days. Cough or coryza, if it is present, then it is less likely, because it means it is more likely to be a viral or upper respiratory viral infection. And on examination, if you see purulent tonsils, that is pus points on the tonsil or a exudate, and severe tonsillar inflammation, that is swollen and red tonsils. So similarly, a Centaur score, that is devised by a American ED physician, I think, Robert Centaur. So that includes age between 3 to 14 years, gives a score of 1. Exudates are swelling of the tonsil, tender, swollen anterior cervical lymph node, and a temperature of greater than 38. Again, the presence of cough goes against it, so there is normally no cough. So with these scores, if it is 0 or 1, it is less likely to be a bacterial tonsillitis. Typically, before this incidents, the scores of 2 and 3, the recommendation was that you can give a deferred antibiotic. You can give a prescription. If things don't get better in the next 24, 48 hours, then they can start antibiotic. And then 4 and 5 score, generally the recommendation was to give a prescription for antibiotic. Now, with the current situation, the recommendation is if the score is 3 or more, to give antibiotic anyway, to have a lower threshold to give antibiotic. Next, please. So the treatment of choice is phenoxymethyl penicillin, that is a PenV, which is normally given 4 times in a day. And the typical course would be 10 days. However, in the current guidance, it says the 5 days of phenoxymethyl penicillin may be enough for a symptomatic cure, but the 10 days course may increase the chances of a microbiological cure. So given the current circumstances, majority of the cases, 5-day course may be sufficient, but it leaves to the clinician's discretion. So I think if there is issues with the supply, it may be reasonable to give a 5 days course and then revisit. If they are better, completely back to normal, then that may be sufficient. If they are partly better, then you may have to extend. So that could be one approach. Phenoxymethyl penicillin doesn't taste that great, and 4 times a day sometimes can be a little bit of a challenge to get all that. In one study, they found that only 40% of the time the parents managed all the 4 doses and for 10 days. So we need to take that into consideration, how good they are in taking the antibiotic. Many children are very fussy about taking medicines anyway, so that may have to be taken into consideration. So the alternate antibiotics that can be used are amoxicillin, which is generally a 3 times a day antibiotic, and a course of usually 5 to 7 days would be sufficient. Clarithromycin is twice a day, and again, a 5 to 7 days would be sufficient. Azithromycin is once a day antibiotic, and generally a course of 5 days would be sufficient. So these macrolide antibiotics, the clarithromycin and azithromycin, can be used in penicillin allergy, including severe allergy. So with regards to the allergy, if it is just a rash, when you have the antibiotic, it could be classified as mild. But if they have a lip swelling or breathing difficulty or anaphylaxis, then it is severe allergic reaction. So the macrolides can be used even if it is anaphylaxis to penicillin. Cefalexin, again, it's a 3 times a day antibiotic, and generally a course of 5 to 7 days would be sufficient. And it can be used in mild penicillin allergy if you have just a rash. But because of the risk of about 10% risk of cross reactivity with the penicillin, in severe penicillin allergy, it is not advisable. Coamoxiclav, again, can be used similar to amoxicillin, but it is a broader spectrum, so better to use it sparingly. It can be antibiotic of choice if there is significant lymphadenitis, cervical lymphadenitis, or quite bad tonsillitis with a significant amount of lymph nodes or enlarged lymph nodes because of good tissue penetrability. So that could be a choice. If there is issues with the supply, the alternate antibiotic that can be used is cotrimoxazole, Septrin, a very old antibiotic, but is very effective. And it can again be used in severe penicillin allergy as well. And it's a twice a day antibiotic. And again, usually a 7-day course would be sufficient. Once they are on antibiotic, a child, if their temperature settles and they have been on antibiotic for more than 24 hours, then they are okay to go back to school as they will not be infectious any longer. So 24 hours on antibiotic and temperature settling, they would be fine to go back to school. Next, please. Invasive group A streptococcal disease, or for short as called as IGAS, is rare but a severe disease. It needs urgent referral to secondary care. And it should be considered if there are features of bacterial pneumonia, that is either reduced breath sounds on auscultation to the chest on a particular area or region of the chest, or there is bronchial breathing suggesting there is consolidation or pneumonia. And usually it can be a complication related to that is empyema. There is a collection of pus around the lung, which normally causes reduced breath sounds. So if there are those features and the child is looking unwell, along with the concurrent or a recent scarlet fever or a group A streptococcal infection, either on the sore throat, or there is a history that there was contact with someone with the group A streptococcal infection or scarlet fever, then they need to be referred to the hospital. If they are looking unwell, the prompt initiation of an antibiotic is the key. I think it needs to be treated similar to how you would have treated a meningococcal septicemia. So if there is going to be a delay of any kind to getting them to the secondary care, you could consider giving intramuscular benzyl penicillin if there are facilities to do so, or even ceftriaxone can be given intramuscular. And once they get into the hospital, they will have a throat swab, blood cultures, and relevant fluid cultures, and they will be started on IV antibiotic. You should not hesitate to give the antibiotic because we may not get the diagnosis, but even if you give the antibiotic, we can identify the organism with the PCR, either from the fluids or in the blood. We can do PCR and the group A strep can still be identified in spite of antibiotic. Next, please.
Ronnie, Shankari, there are some questions on antibiotics. Should we just answer them here before we move on? Would that be all right?
Yeah.
It's up to Ronnie. I was going to let him
take them up?
finish and then pick it up. But, it's up to you, Ronnie. Would you like to finish your presentation and then come back to the questions, or?
Yeah, I think that would be quicker. It shouldn't take
That's
very
okay.
long. So
That's fine, no
problem.
problem.
And then I'll come back.
But we will acknowledge them. We are keeping an eye on the chat. Thank you everyone for posting questions. We will get to them. Either Ronnie or one of the medicines management team will answer them. Sorry, Ronnie, please continue.
Okay, the referral to the secondary care, when to refer. So if there are features of sepsis, someone has high fever, tachypnea, tachycardia, poor circulation, reduced conscious levels. So those all will suggest sepsis, and those need to be referred anyway, as you normally do now. So breathing difficulty, if there is increased work of breathing or the oxygen saturations are low or there is cyanosis, there is pauses in breathing or there are apneas, or if they are floppy or a reduced conscious level, or there is persistent symptoms or worsening of the symptoms on antibiotic, then you need to consider referral to secondary care. Next, please. When to notify. Scarlet fever is a notifiable disease. All severe and invasive group A streptococcal disease should be notified. So the UK Health Security Agency have regional teams, and there is telephone numbers, and usually they take calls during the daytime. When you take history and when you are looking to notify, the important things would be if it is a child, it would be good to note which nursery or the school they attend, and also if there are any vulnerable households, either a neonate less than 28-year-old, a woman who has given birth in the last 28 days, older people at home, 75 years or older, or any immunocompromised people, because they may need antibiotic prophylaxis. So that will help in quick decision making if you have this information to hand. Next, please. Prophylaxis, again, antibiotic prophylaxis may be considered for high-risk contacts like pregnant women beyond 37 weeks gestation, neonates and women who has given birth in the previous 28 days, older households, and individuals who develop chicken pox with active lesions within 7 days of onset of invasive group A streptococcal disease in anyone, or within the 48 hours of them being started on antibiotic, because this will be the infectious period. So the close contact is defined as a prolonged contact within a household setting during the 7 days before the onset of symptoms and up to 24 hours after starting the appropriate antibiotics in the index case, because during that time they will be infectious. Next, please. In the school and the earlier setting, you should contact the Health Protection Agency if there are one or more cases of chickenpox or influenza, that is flu A or flu B, in the class that has a scarlet fever at the same time. Or there is an outbreak of scarlet fever in the school or the class that provides education to children who are clinically vulnerable, maybe special schools who have children with high healthcare needs. Any child or a member of staff, if they are admitted to the hospital with any group A streptococcal infection, or if they have been death related to group A streptococcus. Any issues that are making it difficult to manage the outbreak, that is, if there are issues with antibiotic supply, then they can be contacted. The outbreak is classed as 2 or more cases in the same school or nursery within 10 days of each other, and there should be an epidemiological link that they have come in contact with each other in some context. Next, please. So this is some useful information. So the medicines for children, there is some useful information about swallowing tablets or crushing tablets and how it can be used. There is a very good YouTube video from a ED pediatrician from Leicester, Damien Rowland, and that is through the Royal College of Pediatrics as well. So it can be shared with the parents, and it is addressed to the parents, and NHS guidance you would have all seen, and I have summarized most of that in my talk. That's it. I'm happy to answer any questions. Thank you.
Thank you so much, Ronnie, for that, and thank you all for listening. Obviously, Ronnie's aware of the fact that we have all, different forms of healthcare professionals here today, so you wanted to sort of cover everything that had come through to us as a team that we've been contacted about as sort of general queries. We're fully aware that you guys have been posting lots of questions on the chat too. Thank you to Sophia for going through them, sort of just putting a thumbs up to acknowledge them. Like we said, we might not be able to answer them all today, but we'll do our best. And for the ones that we can't answer during this webinar, we will answer them in written form and publish them on our website, and we'll put the link of that in the chat. So, I mean, I guess if we go from the top, and I can see some of the questions people have answered within the chat, which is great because there's a lot of knowledge between all of us. So someone had asked about using twice a day a double dose. So I'm guessing with the Pen V, if that's an option. Or Naomi. Naomi's here. Naomi Curry is here from our medicines management team. Either one of you happy to answer that?
Yeah, I think we have occasionally used it. I wouldn't say that is the standard practice. I think mainly because of taking it can be a little bit tricky. I know for prophylaxis, we do use twice a day. So it can be used, but because of the taste and the volume, sometimes getting it into children can be a little bit tricky. Naomi, if you have any other thoughts.
I can see Naomi coming in. If you could also answer there was another question around the prophylactic doses and where people can find that. Naomi,
I don't think I have anything to add about the BD dosing. Sorry.
Sorry, the prophylaxis, I think it would be best to discuss with the health protection team, and they would probably guide. But as a rough guide, the Pen V prophylaxis will be twice a day, morning and evening, and probably for 10 days.
Can't take my headphones off, please.
Lovely. I can just hear that someone's unmuted. If I can please just double check that everyone's muted themselves unless they're presenting. Thank you. Can erythromycin be used?
Yes, erythromycin can be used, and it is 4 times a day for treatment. And I'm not familiar with using it for prophylaxis as such, but treatment it can be used, but 4 times a day.
Lovely. People did ask again. Naomi, did you want to come in?
Yeah, just sorry, you can use erythromycin, but there is increasing resistance to streptococcus with erythromycin. So I would go with the other macrolides first. Obviously, if you can't then get hold of those, then erythromycin is an option. But the recent ESPAR report did say that erythromycin resistance was increasing to streptococcus. So that's why we didn't put it in as our sort of first line macrolide. But it's probably, if you've got someone who's pregnant, probably an option because it's preferred macrolide in that group. Sorry.
No, thank you, Naomi, because I think I sort of automatically shook my head when erythromycin was mentioned, but that's useful to know. There's always exceptions in there. Someone asked about swabbing. A couple of questions about swabbing. I think the answer is if you're suspecting scarlet fever, then yes, please do, because it's notifiable. Would you all agree with that?
Yes, and I think if you're treating and if you have an opportunity to swab, then it might be better just to get information. And also, as we said, sometimes there can be a deterioration in a few days, or if there is any kind of invasive, or also in the school and the nursery context. So if there is opportunity to do so, this is advice from our microbiologist as well, because as we are just entering into a more national type of picture, it may give us better information. So if there is opportunity to do a swab, then it is better to do at the moment. But if it is harder to do, then for milder cases, it is not required. Scarlet fever or any suspicion of invasive group A strep, then yes, definitely.
Yes, essentially, if you're suspecting or highly suspecting it, or if you're worried that they might deteriorate, it might help us with sort of future decisions, really helping the clinicians who might need to see that child in the future. I think people ask about scoring when swabbing. I think you can use the scoring for helping you identify some of the more severely sick children, but again, the same rule applies. I'm not ignoring the questions around pharmacy and supplies. It's just we're going to come to that because the medicines management team is going to address it. So I'm just going to skim past that because we're running out of time a little bit. I think the message around prophylaxis is that we do prescribe it, but we discuss it with the health protection team first to get advice on it and who gets it. It sounds like there was a slide on that Dr. Misquith showed. So the vulnerable people in the same household, so those over the age of 75, pregnant, those who've had coexisting infections, such as chickenpox. And again, we're happy to share the details of this, and it's all in the GP bulletin today as well. What I'll do probably at this point, just to keep on top of time, we'll keep an eye on the chat. I'll probably close it off at here point. I'm just going to close it off at this point so I can sort of skim through them and group them. But in the meantime, if I can hand over to Naomi, are you happy to do your bit on the medicines management? Thank you. Thank you, Fiona, for being here as well today.
No problem. Thank you.
Thank you, Ron. Dr. Misquith.
I've done a couple of slides around treatment, but Dr. Misquith has covered that anyway. So actually, I'll move on to some of the practicalities, and Fiona's here as well, just to kind of address some of the supply issues that we know you're currently dealing with, and we're trying to support with. Let me just share my screen. So, as Dr. Misquith has already said, when do we prescribe antibiotics? Just to make everybody aware, I'm sure you've all seen this guidance come through, but the UKHSA issued interim clinical guidance on Friday around Group A strep management in children. And yesterday, NICE have updated the standard NICE guideline around sore throat, so that it only refers to children. It only refers to adults. Apologies. It only refers to adults. For children, we're to up until January, we are to refer to this interim clinical guidance. And as Dr. Misquith has said, it's basically moved the goalpost of when you would start antibiotics. So treating patients with a fever pain of 3 or more. that we've already gone through. So just to go through some of the practical advice that we can be giving to parents who are perhaps struggling to get supplies, because we are seeing a massive demand on the liquid medicines, where the guidance that's come from NHSE is around encouraging children of 5 years and above, where it's possible in terms of dosing, to be that they may be able to swallow tablets and capsules. And there are some really brilliant resources come through from Kids Meds about how you encourage your children to swallow tablets. You know, I'm a mum. I'm currently trying to get my daughter to take amoxicillin liquid. It's pretty disgusting. So actually, in some cases, this might be better to actually get them to try and swallow a tablet if they're capable and a little bit bigger. And it's so much less messy in terms of taking it to school and that kind of thing. So I would really encourage you to share some of those Kids Meds resources and encourage those slightly older children to take tablets and capsules, because there does seem to be more of those available in the community pharmacies. We also had some guidance come from the NHS Specialist Pharmacy Service around the off-label use of various antibiotics and how to give doses by dispersing or crushing tablets or opening capsules. I've done this is just a very brief, which ones can be, but actually if you go on to that advice, it gives lots of practical advice around dispersing antibiotic tablets, opening up antibiotic capsules, mixing them with food, disguising the taste. So if you do give tablets or capsules to children over 5 or 6 years and they can't swallow them, then there perhaps is some off-label ways of using those medicines. So I've put all of those links, and we can share them all in the chat with people as well, so that you can have a look through those. And I will hand over to Fiona to talk about supply if she's there.
Yep, I'm here.
Thank you.
Naomi, can I ask you before you put yourself on mute? Andrew Potter has asked a really good question, and I know we've looked into this about the accuracy of the point of care Strep A testing kits, the lateral flow tests.
Yes,
we did look into this, Andrew. There is nice guidance on these, and they're deemed not cost effective for the NHS because they're not deemed to be any more accurate than the fever pain scoring. But Naomi did look into them, and I know you know the selectivity and specificity, and I think we should cover it.
Not off the top of my head, I don't, but they were reasonably specific and reasonably sensitive. It was more around actually how much did it reduce antibiotic prescribing. I think we were looking at it with a different head in terms of, we were having a conversation about you could use it as a reassurance and a screening out negatives, but there is talk about there being false negatives from the lateral flow type testing kits. So they are relatively sensitive and specific in answer to that question, but NICE have said they are not cost effective because they're around £3 a test for the NHS. So in terms of a cost per QALY, it was way above NICE's limit. So that's why they had not recommended them. Does that answer the question? I'm not sure I've seen the question.
No, that's great.
I can't, because I've got I'm presenting. I can't see the screen.
It's just, Andrew, I was also going down that route, but we did. We've been naturally advised not to. So just to comment on the antibiotic supply, and we've broken this down into 2 tiers. We are very aware this is a significant issue at the moment. So nationally, a medicine supply notice was issued yesterday. And what is currently going on nationally, the Pharmaceutical Services Negotiating Committee are currently negotiating with the Department of Health, because with the supply issues, a lot of pharmacies are having to get the medicines from what we'd call shortliners, because that's all that's available. And so they will be looking at bringing in an NCSO price. At the moment, pharmacies are supplying, but are very aware some of them are having to do so at risk. NHS England are also working with the Department of Health and Social Care. There is enough stock in the UK. The problem is it's all in the wholesaler. It's not in the wholesalers, it's in the manufacturers. And so the bit that is outside of our gift control is getting the stock out of the manufacturers into the wholesalers at a volume that will supply all the pharmacies with sufficient to break this cycle of being out of stock. But that is being worked on nationally, and we are assured in the actual manufacturers there is significant stock in the UK. They're the bits we can't control. Locally, what we're doing, we have, pre-COVID, we set up some optional community pharmacy WhatsApp groups to help communication. These were surprisingly successful, and community pharmacies have been using these since February, March 2020 to deal with all the out of stocks. So what the pharmacies are now doing in their groups, there's one for Bedford, one for Milton Keynes, one for Luton, one for Leighton Buzzard. All the pharmacies in the morning are posting in the group the name of their pharmacy and what they have in stock that day, which means if a patient goes to a pharmacy and they don't have it, they can have a look in the WhatsApp group and say, I haven't got it in my pharmacy, but the village pharmacy down the road's got 62 bottles, or they did at 9 o'clock this morning, I'd go there. So they're proactively signposting patients to where the stock is. This seems to be working really well. It didn't work so well on Sunday when lots of pharmacies were closed. But speaking to some of the bigger companies, so I spoke to Jardines yesterday and spoke to Christian Modi, who's the managing director of Jardines in Milton Keynes. All Jardines pharmacies have good supplies of penicillin and amoxicillin liquid because they had already stocked up for Christmas and have significant supplies. So I think within the system there is enough. It just might not be in every pharmacy. What we're recommending clinicians to do, if you're seeing the person if you're seeing the patient in person, give them an EPS token. So don't send it down the spine, give them a token. That way they can take it to a pharmacy that's got it and then they'll pull it down the spine and dispense it. If you are seeing them remotely, then send it to their normal pharmacy. They can push it back up the spine and another pharmacy can draw it down again. It is a little bit more clunky and labour intensive and takes time. So the token works better, but that is an option if you're not seeing the patient. And then some pharmacies are proactively working with local surgeries. Where we've got smaller systems where we, like Alsey, for example, where there's one pharmacy, one surgery, they're just messaging the surgery in the morning and saying, this is what we've got, this is what we've not got. Clearly areas like Bedford and Luton where patients could go to any pharmacy, that isn't going to particularly work. So they're using the WhatsApp group more. But I think they're doing what they want. So Carol, I've noted your comment. I think if your pharmacy are not doing that, I would contact them and just give them a generic mail address and ask them to email you in the morning. So then you can send an instant message around your team. But you need to really work with your own local pharmacies because locally this seems to be working much better where people are taking local ownership. So I won't say any more, but I think that's as much as we can share with you at the moment on the supply issues.
Thank you for that, Naomi and Fiona. And I think I absolutely feel the pressure, every time you start your clinic and you know that there's lists of pharmacies that are telling you that they're out of stock of X, Y, Z. But I guess the main message is that actually the antibiotics are out there, they're just sitting in different places. And like Fiona said, if it's possible, at all possible, ideally, children under the age of 5, we'd like to see them anyways. If we think it's got a few, we would swap them. And if you're then going to prescribe an antibiotic, ideally prescribe it within and give them an ETP token so they can take it to their local pharmacy and they will then be able to tell them, look, I don't have it, but this pharmacy has it, go there instead. So kind of leave it to the pharmacies to coordinate that as much as possible, and if not, then try and see if you can get them to write into you every day, but it is a different approach every day, I'm afraid. On that topic though, so one of the other questions was around, is it possible to put multiple alternatives of antibiotics on the same script? So so that the patient doesn't bounce back, and I can see the thinking behind that. So if you say Pen V, but if out of stock, please give this instead. Would you recommend that? I'm guessing the answer is no, and I don't think the pharmacy will know to not give one of them. They'll probably try and dispense both. Is that correct? Even if you handwrite it.
I think that's the risk, yes, Shankari. If you put both on, the risk is that they'll claim for both and dispense both, and then you've lost 2 bottles of antibiotics. Unfortunately, I see where you're coming from, but I think if we can choose the antibiotic and try and get the patient to the antibiotic, that's probably a better channel than
sort of
offering
decide on
options.
one antibiotic and let them find it at the right pharmacy that has the stock. There's so many questions coming in.
So
it's really...
I'll just theme them a little bit, Shankari, for you now. So there are quite a few questions, Fiona, on colleagues asking, what is a token?
So the EPS token is the paper copy of an EPS prescription. When you do an EPS prescription, you can send it up into the spine, but you can print a paper token and it comes out as a prescription with a barcode on. When they get to the pharmacy just scan the barcode and that just draws the prescription down off the spine.
So just to go, so on system one, you're prescribing, you put in your PIN and the prescription is done electronically. And then when you say print, so, you know, at the end of it, it says send now or send and print. You print only. There's a third option where you just print it. It gives you a token. It says not to sign it because it's just a token. Your signature is electronic when you put your PIN in, and then the patient or the parents can take that around and find the antibiotics where they are.
Okay, there's a question from our community rapid response service saying, can they use tokens in the children's rapid response service? So they're in Cambridgeshire Community Services. So do you have an answer there, Fiona?
It depends if they use EPS or not. I'm afraid I don't know if Cambridge Community Services use EPS. I think they do. And if you use EPS, 100% yes, it's a function of EPS.
I believe they do.
Yeah, I think they do. There's another question. There's some questions around the over-the-counter test, Fiona. So I know you've answered it, but maybe colleagues have joined late. So just the fact that over-the-counter tests.
So large numbers of our community pharmacy colleagues are using and offering the Strep A test as a private service. They're doing the fever pain scoring and offering the test. I have to say, actually, I think they're being very helpful, because what they'll probably do is screening out the worried well for you. Because actually, if somebody scores 1 or 2 on the fever pain and the Strep A test is negative, they probably have reassured that family, and their parents have gone away with the child and haven't come for an appointment. So actually, I think our community pharmacy colleagues are doing a good job. I appreciate in terms of health inequalities, isn't ideal, because it's those parents who are prepared to pay the £15 for the consultation and the test. But I suspect, having spoken to some of my community pharmacy colleagues who are offering it, what they're saying is if they do 10 tests, 9 are the worried well that they just send away happy. They might have 1 that tests positive, who they then have to refer on to the GP that needs prescribing. So I suspect they're doing quite a good job of reassuring the worried well.
I guess the same rule as always, but especially right now where the demand's so high, where we can sort of push towards sort of self-care and other parts of the system that have more capacity. But one of the questions that also stems from that is, what if it comes back positive, having done a private test, but the child is asymptomatic? So when it comes to can you prescribe, would we still prescribe because it's a notifiable disease? I guess it's symptomatic. You treat the child, not is my answer. But yeah, lovely. Perfect.
Yeah, so you would treat the symptoms, but what you may want to do is swab the child in case you get a positive swab back, but you probably wouldn't prescribe if they were asymptomatic. Agreed, Naomi?
I think the answer was if it comes back positive. So if they've done the swab in the community, it's come back positive. But the question is, why did they do the swab in the first place if the child is asymptomatic? So I'm guessing the child's improved, in which case you wouldn't treat it because the child's already naturally recovering.
There's a natural level of carriage as well, isn't there? 10 to 15%. I can't remember the exact percentage, but you know, a certain proportion of the population carry it in their throat. So you're going to get some positives where there's no symptoms, just from natural carriage.
I believe my daughter's one of those. So it's an incident to find it a couple of years ago.
Yeah, Fiona, there's a question around the information that's gone out from Meds management team. So all of that information's gone out before, but has also gone out through the GP newsletter today again as well, isn't it?
Yeah, so we've sent it out as an urgent email on Friday, and we sent that to also all community pharmacies. So one of the GPs has posted about, have we said to the pharmacies? Absolutely. So we've been sharing everything with the pharmacies as well, and it's been in the primary care bulletin today. So if you've lost the email, you can just search within the primary care bulletin, and all the information and all the links are there. And I checked the primary care bulletin today and it definitely is there.
Okay, I think those are most of the questions. There's some more questions around swabbing, but Ronnie, if you're still on the call, do you want to just reiterate for colleagues who are joining late around the when to swab question? I think that's another big question that's coming through.
Yeah, I think the swabbing is routinely recommended if there is a scarlet fever or if you're suspecting invasive group A streptococcal disease. In other instances, if possible, you swab if you're going to treat them with antibiotics so that at least 24, 48 hours down the line, there is certainty. And if there is a deterioration, then hopefully you would have had the results back. But for mild cases, it is not a must. But if you have an opportunity to do so, then it would be better to swab it. But scarlet fever and invasive streptococcal disease, it is recommended to swab.
And I think there's a question around how soon are we getting our swab results back? And colleagues, if you don't mind posting your question on the chat function, if you've got a raised hand, if you could kindly post your question, that'd be really helpful because it might help others as well. So Ronnie, just question around how soon are we getting our swab results back, if you've got any.
Yeah, so that depends on how quickly it gets to the lab. So generally we should get it in about 36 hours, between 36 to 48 hours. But there is some delays in the transit and then plating and reporting as well. The standard time will be 36 to 48 hours, but depending on the demand, it may be slightly longer.
Okay, so there's a question around our out-of-hours service, who are seeing a lot of cases. So we're seeing a lot of children in our out-of-hours service, but we cannot arrange swabs. Should we ask their own GP? Shankari, do you have an answer to that?
I mean, it depends. You should be able to request the swabs from out of hours. It might be useful for us to know exactly which service you're working under. We could certainly go back to those and ask why that's not possible. There's no reason why that shouldn't be done. Much like an MSU being sent for MCNS, it's the same kind of microbiology and sensitivity one. So that should not be an issue. Just to also let you know, Ronald, there's 2 links that you shared in your presentation. I've sort of copied them onto the chat. They weren't functional. We will look into that and we will share the 2 links that are functional. Sorry about that.
We can post.
Which one wasn't working? Sorry,
So both
I can
the YouTube,
get in touch with you.
Both the YouTube one and the RPCH one. That's fine.
And
this chat will keep open. So.
Yeah, Shankari, we can post Ronald's slide pack onto the chat function now so people can download it. Would that be okay, Ronnie? You were going to ask us to do that anyway.
Yeah, that's fine. That's fine.
Yeah. Okay. I think we're coming to the end of time, but I'll leave you to it now.
Do you mind if I just if I get Simon Harcaster to quickly come in? He's here from the ICB as the Emergency Preparedness Response Team. And he's just going to give us a quick update, just a bit of an overview. Thank you, Simon.
Hi, thank you. Good evening, everybody. Simon Hardcastle, Associate Director of Quality and Safeguarding. I'm actually on call this evening, and Richard was meant to be here. Unfortunately, we've had to swap because of other system calls taking place. So just to give an update in terms of where we are in some of the data, I think that might be helpful in terms of the challenges within the system. So from a 111 perspective, both DHU and Hook have been operating on Opal 4 across for the last 3 days. So obviously both those services seen an increase in activity and a lot of that has been in relation to calls around Strep A. Yesterday, Hook themselves declared an internal critical incident with approximately 300 calls at one point waiting to be answered and assessed. So that still is a challenge across the system. Primary care averaging 193 calls a day, with at least 50% of those calls being under 16-year-olds, with practices having themselves also significant pressures. Medicine supply, obviously, we've already covered and had that update, which is really helpful this evening. And the other piece of news is around the hubs, in terms of the acute respiratory hubs. So just to let people know, the current SOP has now gone to PCN leads for formal feedback and proposals to be back by tomorrow around, obviously, how that service will be delivered and when that can be mobilised. Obviously, this is about looking at supporting in the community hubs that will be staffed by teams around once patients have been discharged from hospital for their follow-ups. So that hopefully the feedback will mean that we're in a position to look at mobilising that this month. So once we've got that feedback around that, then obviously further communications will be coming out. But as well, just to say, obviously, we are meeting twice a week at the moment in terms as a system to review the ongoing situation, and obviously we'll feed back at each opportunity we can. But also, just obviously to thank you all for your patience and perseverance at this very challenging time, and the way that everyone has come together. And just to seeing the number of people on this call this evening just shows the how we can collaborate and work as a system to help achieve what we need to in terms of this. And my door's just gone, so the dogs will bark, so I'll be quiet now.
Thank you for that, Simon. Like all of us have said, thank you all so much for all the continued work that you're doing, but also for turning up tonight. We weren't sure if this is the right day or time for everyone, but we're happy to try and do this on a regular basis if that's helpful for you guys. We'd like some feedback on that. We will try and put an evaluation survey into the chat at some point in the next 24 hours or so. Someone, if you guys can keep an eye on that and let us know what would be useful and what form of communication is most useful. We'll try our best. We'll also try and keep an eye on this chat. So going forwards, if you do have queries that crop up, if not now, please post them in here and we'll do our best to try and get back to you. And we'll probably answer them either in chat form or possibly on our website, because we're going to start collating sort of frequently asked questions so it's accessible to everyone, not just everyone who managed to make it today and be present. Just also to say, OPAL, for those of you who might not be aware, stands for Operations Pressure Escalations Level, and level 4 it just means high escalation level, so unable to deliver comprehensive care and patient safety is at risk. So really high levels of stress there. And that's what Simon was just talking us through there. Lovely. Just need to. We've got 6 minutes just to sort of tidy things up.
Yeah. Any questions, colleagues? Please please post on this chat link. We will keep this chat link as a way of communicating. So you will have communication through the newsletters that go out and through some of the other forums. So please keep an eye on those as well. But we will open this, we'll keep this chat link open. So if any questions are posted here, we'll pick those up and we'll try and answer them. Just to mention, we've got a website where all of our BLMK children's urgent care pathways are all available, with also the parent care information leaflets that we've devised, and we've always had them, but it might be worthwhile us refreshing us around some of that. So we will post the link for that too. And then there is a parent-facing website as well, and more comms that's going to happen over the next couple of weeks. But please tell us if this is helpful, and we'll continue to hold some more webinars to keep a open conversation. So thank you again for all of the hard work, but let us know how else we can help you. Thank you.
Thank you all.